So I'm here with Tyson McEwen, and Tyson and I have had a long-standing relationship, both personally and professionally. Tyson works at Noosa Confidential, our rehab, where we treat drug addiction and mental health challenges and chronic pain, because they all frequently are tied in together. And I've also personally been working with Tyson for my own chronic pain challenges. So Tyson, welcome to the podcast.
Thanks for having me.
So let's kick off. My backstory of chronic pain: I had a hip replacement at 45. I had a hysterectomy at 45. I have arthritis, and I have what you like to call a bit of a funky pain system. And I know you've had your own relationship with pain. Can you give me a bit of a background, how you came to this work, what your personal experience is, if you feel comfortable, and then kind of professionally, what you then studied and what your direction has been since then?
Yeah, wow. It's a good question and a very long answer. But what I'll do, I'll try and summarize it pretty quickly. So I had a first injury when I was 13. I did a stress fracture in my lower back. And then the first person that I saw was a manual therapist who did a special manual therapy technique that it would realign muscles, tendons, and ligaments. He treated me, my pain wound down, but I'd have to keep going back and have this technique done every week to 2 weeks, and then basically became reliant on it. And just with the language around what the technique was doing was kind of keeping me in that model long term.
Can you give an example of those languages? Because when you say a manual, you're meaning people like osteopaths, chiropractors, Bowen technique, Niblett technique, like people who do manual adjustments. Is that what you're talking about?
Yeah. So basically, that all those examples you've given are forms of manual therapy. So as soon as someone starts to touch you in a way, like a passive way, where they're doing the work and you're not doing the work, that becomes a passive treatment. And it's really good in the research. It's good for reducing or calming pain down short term, and improving range of motion at joints short term. But for long term or chronic persistent pain, it's not a fixed thing. We need a different approach, which we'll talk about later today. But just to continue on with what I was saying is, I got stuck into that model of I needed that person to get rid of something that had become misaligned, or that's the only way to calm down my pain. I ended up taking over the business and learning under this person, promoting that form of treatment for all types of pain. Ended up getting to a point where I burnt out, quite a lot of pain in my lower back because I was away from the person who was doing the special treatment, and ended up going to a gym, and a PT got me to lift way too hard, too fast. I ended up doing another stress fracture on the same vertebrae, which then went into a slippage, which in the research they call it a spondylolisthesis, or basically the vertebrae slips forward slightly. But and then I did a PT course because I was like, look, I don't have that person to use this technique. How do I start to move forward in life and rehab the area? I ended up going to university to study exercise physiology. And then while I was studying in my first year, I got an internship at Amy Park in Melbourne and worked for a performance company called ESS Performance, and ended up getting the job out of 15 people and became an assistant strength coach. But still, the interesting part is everybody inside that center, as well as everybody that I'd met during my university studies at that time, was stuck in kind of a model of we need to use exercise to fix a malalignment or things being in or out, or that is the reason for your pain. There is something happening at the tissue, versus taking a broader approach, which we're seeing in the science of pain now. And those things matter a little bit, but it's not the whole picture. It's about how long's a piece of string for the person, or what are the contributing factors for each individual. The advanced rehab was around the pelvis being twisted or tilted, discs kind of being imbalanced with malalignments, the core being weak, etc., versus actually more of a broader or a complicated model in what we see with the science of pain. 2 years ago, I decided to get involved with a charity called Pain Revolution. Now, this is a charity that Professor Lorimer Moseley founded, and it was a way that he wanted to get pain science into rural communities to try and tackle the opioid epidemic and the chronic pain epidemic we're seeing globally. And as we know, rural settings are kind of disadvantaged by health professionals, also GPs. A lot of talk about GPs, but not much about allied health professionals, which they're also lacking in. And if we don't have these people who are pain informed, then their management of chronic pain is going to be very pharmaceutical based.
Yeah.
So we've got
then we head into addiction.
Yeah, it's addiction with opioids, sorry. So I ended up doing part of Pain Revolution's, I guess, model is they'll sponsor people to do a graduate certificate in pain science via online study at the University of South Australia.
Yeah.
And then from there, you'll do a give back period for the next 2 years where you'll run a local pain educator for allied health professionals to come and learn about pain science. Local pain collective, not the educator program.
And where we crossed over, so as you said, started with PT, have your own pain background, I have mine, had worked with a colleague of yours who was also an exercise physiologist, which is, I think, where the crossover was in Puana. And he started to educate me. I've trained all my life, lifting weights. My mum owned one of the biggest gyms in Australia when I was a teenager. So exercising and lifting weights as a woman is not something that was new, but how that related to pain in my body, but also inflammation and trauma and psychological pain. And certainly you and I have worked together and you've worked with some of our trauma therapists. Can you talk about that relationship? Because we at Noosa Confidential will have clients that show up with addiction, and then we know that that is generally correlated to trauma, and then that generally is connected to some type of pain in the body or beliefs about pain or restriction or limitation. And so then you'll get them into the gym and want to have movement, because we know movement is more effective than most SSRIs to lift depression, to reduce inflammation in the body, and therefore for them to experience a psychological easing of distress. So that's how you and I have really started bonding even more, which was integrating movement with psychological treatments, and that is intricately linked with what we now know is more updated pain science. Can you kind of talk about that at all?
Yeah. Big thing is it's complicated, and it's complicated because we've all got different genetics as well as a life story. So we all go through key events through our life which can prime our central nervous system up and make our central nervous system more protective from a pain. Certain key events can prime the central nervous system and then put someone at risk to have pain more easily. What we see is it's about what's in the cup. We've all got the cup happening in our life, and how many contributing factors are in the cup, and then all of a sudden the cup overflows and we're experiencing pain. Now, currently, most health professionals, when someone comes to them in pain, they will be looking at tissue issues, which might only be about 10% of what's driving someone's pain system upwards.
Mm-hmm.
The big thing is a lot of those things you're saying is, okay, someone comes with addiction or trauma and all these things. Well, that can be layering in the cup and amplifying someone's pain system. Now, that's a really probably easy way to look at it. But if we look at the way the brain works is we've got a meshing of sensory information coming in from all our sensory systems. So all our tactile sensors in our skin, from our muscle spindles, from different types of sensory cells in the ligaments, our danger detectors, which are in every part of our body that feeds information to our spinal cord. We've got all our visual system, auditory. So that's all kind of, if we just think of everything coming into the spinal cord and then meshing into the similar pathways, we've got danger detectors that are in the spinal cord as well. And that meshes information up to the brain. The brain's going, I'm getting a lot of information from my knee, for example. This is from my danger detecting system. What's going on? You look down at your knee, it's bleeding. Okay. So now the visual information is coming in. We've got the danger detector information coming in, and then it's giving us then the perception of pain. And that's from this sensory information meshing with not only stored information, which can be trauma, beliefs, attitudes towards pain. A lot of these things we get from, obviously, trauma can happen any time of our lifespan, but if it's happened during our childhood, then our central nervous system could have been primed to be a bit more protective. And then beliefs and attitudes we get from society, but also from our parents. We see people with chronic pain, people who've had parents with chronic pain, they're more at risk of having chronic pain. And we're seeing that that's probably more about beliefs towards pain and the meaning behind it, which could be amplifying someone's pain system as well. So it's kind of just think of it, all the information coming into the brain, but also everything that's been stored there, meshing together to try and work out whether or not you need to be protected. And to put it simply, it's about a balance between safety and danger. So if there's more credible evidence that there's danger either to our bodies internally or externally, then we can get pain. Pain system can start to wind up.
Well, very interesting, because we now know, and this is, I want to kind of dance between what we used to think, and I can talk from a psych perspective, and you can talk obviously from an EP and pain science perspective. And you mentioned there sort of beliefs can really influence things, because certainly when we are parenting, you're a parent, I'm a parent, you have this primal desire to protect your child. And obviously there's a time to protect your child and to keep them safe, and particularly in early childhood. But ultimately, if that remains the priority, more and more, particularly in our current society, there is a desire to keep people safe, which seems logical and seems like a really good intention when you think about it. Of course, you want to keep somebody safe, except that the more safe we are, the more we avoid discomfort, the less we grow and the less resilient we are, just as a broad kind of statement.
Yeah.
And from a psych perspective and a relational perspective, I can look at that and say, yes, you're less robust, you're avoiding discomfort, you're therefore not deeply connecting with others because you're keeping yourself safe, you're keeping yourself in victim by avoiding discomfort. And I noticed you said at the beginning, the manual adjustments where they have their value in terms of feeling better or reducing inflammation, they're passive, and you said you're not doing the work. Somebody else is doing something to you to make you feel better. And I see that very much from a psych perspective. They're looking for modality, CBT, DBT, whatever narrative that, like, what therapy, hypnotherapy, what modalities do you use to make me feel better? And I will often say, I'm not doing the work. I'm not here to fix you. I'm here to help build you up, for you to be in application, for you to reduce inflammation and challenge your stories and rewire your brain in real time, because we know that actually, healing is not a place, or healed is not a place that you get to ongoing. It's constantly evolving, and something being uncomfortable or even painful doesn't mean it's bad or wrong. It just means it's uncomfortable or unfamiliar, or you don't really like the feedback you're getting. But I think that's a bit of a distortion. Even things like, I know now with pain, wrapping things or wanting to wear something to make it feel safe when you've hurt something or rolled something. Like, I have found the last few years of education and working with you, and obviously me then marrying that into my work, realizing there's so many misunderstandings and processes or solutions that are not really solutions. And the difference between something that feels better, feels like it's doing something, versus something that actually is doing something. And this is a big theme with me, with my No BS with PS, which is calling BS on things that you think are effective or you think are true. It's not true. So what does that mean to you? How do you...
Well, it's layered again, but the big thing is perceptions. To follow on what I was saying about the meshing of information, when we get pain, it is a perception. So once we start to understand it is a perception, and the only difference between an emotion and pain is pain is felt somewhere in the body. So once you understand that, then you can start to reconceptualize pain and understand that we've got to look at contributing factors and why am I perceiving pain somewhere. As soon as you start using that language, you can start to recognize it's a warning system.
Yeah.
It's a protective system. It's not a good indicator of damage at all. So straight away you go, okay, my perceptions can be inaccurate. So how do we use logic to work out, is there a tissue issue or is there a pain system issue? Because they feel the same. That's why body is going around saying the world is flat when it's actually round, because it's got so much evidence that it's flat, because that's what people are experiencing. I've done something to myself. And sometimes they may do something to themselves, but there's going to be a proportion of the population that have their the central nervous systems primed, and that they're more likely to have pain, and their pain system is more protective. And I see it as a great thing, because guess what? You're less likely to do injury. But the thing is, when we are experiencing pain and we have an old model of pain, we will be avoiding movement. And the conundrum is the movement is what drives the pain system to calm down, and what drives the tissue quality to improve. Because the avoidance then, because people avoiding, you do a downward spiral. You're avoiding movement, therefore your brain is not getting mood food, and you're getting depressed, and you're obviously anxious, and we know our guts can get impacted through a lack of movement as well. And then we have more pain because our system the dial knob just keeps turning up. So we have to slowly get people moving towards exercise at a gradual, pace, which is called graded activity, so that we're on this side, we got tissue damage, we got our pain system expands. Yep. So now we're working on this line. We've got a big buffer zone there between tissue damage and pain. Normally it's about here for normal people or pre-injured state. Yeah. Sometimes we jump over the fence and fall down the cliff and do a bit of damage. But people who've got pain system issues or have had long pain longer than the normal stages and phase of tissue healing,
which would be called chronic pain, right?
Yeah, which is chronic pain. We're now calling it persistent pain because people are getting confused what chronic means. So
that's a really good point to make. That's why I'm asking, because a lot of people say, I've got chronic pain. It's like, what does that mean?
Yeah, they think it means like it hurts a lot.
Yeah.
Versus actually it's been around for a long time now. When we see pain system issues, is our pain line has moved further away from tissue damage, and the person will touch the pain line very easily with even low load movements that don't have enough load to do damage to tissue, but they're experiencing pain from it. And they go, I've done my back again, or I've done my shoulder, or whatever. Done. And that the thing is this, which makes it even more confusing, is that protection by pain line is dynamic. So the person has a good sleep, all of a sudden it moves, moves closer to tissue damage. We got more room to play, and all of a sudden getting in and out of the car doesn't hurt anymore for a couple of days. Oh, my back's good again. Then they'll go too hard, too fast, hit their pain edge, they'll create a flare up. So it's about kind of doing behaviors over here which help slowly nudge that pain line back to a normal protective level, and gives us space to move in our life where we don't hit the edge.
And for women, I want to make the point as well, as a woman with persistent pain and interesting pain pathways, etc., it can be different depending on where you're at in your cycle, how you experience pain or what you feel capable of or not capable of. I remember you and I talking to our chef at Noosa Confidential, and she lifts as well, and I train with her as well. I surf with her and exercise with her. And remember, she had, her language hurt her back, but didn't know what to do. And I remember the three of us sort of hashing through, well, is it a tissue issue? What were you doing? Nothing wrong, nothing, in inverted commas, nothing unusual. And then we managed to get clear that actually a psychological event or a stressor had actually happened in an hour, around her training time. And there was no injury, so to speak, but the pain pathways had flared up because of an event that had stressed her out. Can you talk about that a bit?
We know cortisol and adrenaline can pass through certain structures of the spinal cord, the dorsal horn root, and actually sensitize the central nervous system. So anything that kind of brings us up into fight or flight can potentially turn the dial knob up at the spinal cord, or down, depending on what's going on for the person. Also, we know sleep obviously can make the system more sensitive. That's only one aspect. Now, with our stress response, we can see that even without kind of those things amplifying messages at the spinal cord, because there's basically normal messages will be coming in, but then they're getting amplified and sending up to the brain at a exaggerated rate. But we can also see that the pathways coming down that kind of block some of these messages start to not work as efficiently, which they call it descending inhibitory pathways. But even if we weren't at the spinal cord, stuff happening in the brain, we know that a nerve pathway or a group of nerves can wear many hats. So let's just say that that person was going through something with a spouse, or someone's passed away or whatever. Certain things that have happened with that person can be linking into some of the pathways that are actually giving evidence that the person needs to be protected. So it might be meshing in with visual information, a little bit of danger detecting information coming in from the periphery. It can be a belief and attitude around their back. It can be anything you can think of. Basically, everything is getting meshed in the brain, and everything we think about is being meshed in the brain. So it pretty much can be anything that gives evidence that there's danger in our surroundings.
We're not safe.
Yeah. And so it doesn't even have to be with changes to our stress response, or what they call the HPA axis, where we've got dysregulated cortisol, all that kind of stuff. But yeah, we all also know with cortisol is if someone has a lot of stress long term, where we're going to be spiking our insulin levels up, and then we're getting some low-grade inflammation, which diabetes is the extreme. And these things can cause issues at the gut, issues at the liver. We know osteoarthritis is a low-grade inflammatory systemic thing now. We're not seeing it as a wear and tear. It's at the joint. It's at the system. It's what, has the person been moving enough? Have they been eating well enough? What's their stress response been long term? How are they managing blood glucose levels, or how's their insulin sensitivity? So it's all linked in together. It's like, which one is it? But yeah, in that example, if we use logic again, she hadn't changed her volume or loads with her weights that she was lifting the week before. What we could say is, yes, her stress response is up, so there may have been some delays in her tissue healing or ability to recover from the previous workout. She wasn't progressing with load as well, so it's kind of most likely her protection by pain line has moved, because I've said before, it's dynamic. It can move back and forth, and all of a sudden certain movements over here that she normally her system doesn't see as protective, starts to get seen as protective, and we hit that edge.
Yeah.
Because she wound down quicker.
Yeah, really quickly.
Yeah, it was like a couple of days. Down quicker than a tissue issue would have taken.
Yeah.
Yeah. But just I think probably what's important, so I haven't spoken about kind of the different types of pain. Now, the International Association of Study of Pain have tried to categorize different types of pain to try and make it simple, but basically we're seeing it can be a meshing of any three categories at once. It doesn't have to be, it's just this type of pain, or this is the main contributing factor. But we have in the research central sensitization, which with Pain Revolution charity, we're calling pain system hypersensitivity. And we have neuropathic pain, or issues with a nerve injury or disease or lesion to a nerve, signaling issue. The pathway between the tissue and the spinal cord has been injured. So there's no tissue issues, just the nerves not working properly. And then we have stuff happening at the tissue, which is an immune event. The immune system, the immune cells have migrated to the area, and they're trying to clean up debris, and they're actually amplifying and sensitizing the danger detectors from that area, which, by the way, are called nociceptors, and the pathway between the tissue issue and the spinal cord.
And in that last one, you would normally see actual physical inflammation.
Yeah, so that's where we go, okay, we use logic again, is most things, sometimes we can't see things because it can be deeper in the tissue, but you roll an ankle, you'll see bruising and swelling.
You'll see bruising and swelling.
Exactly. Yeah. And the thing to differentiate between tissue issues and pain system issues is pain system issues will like heat, tissue issues will not like heat. And that's to do with when the immune cells are out cleaning up the debris, the danger detectors become sensitized to other noxious information. So noxious means potential threat, stuff that could threat or harm us. Heat, chemicals, and mechanical load. So it becomes sensitive to heat. So
pain system issues like heat, meaning a hot water bottle, or will feel soothing and
soothing. Yeah. They'll be sensitive to pain system stuff will become sensitive to mechanical loading, but not heat. It'll enjoy heat.
Yeah.
Where tissue issues won't like mechanical loading, and it won't like heat as well. It'll actually make it feel worse.
Okay.
So it's a good little hack to try and work out where, which one is it. But we also have these kind of more mixed presentations where some will have osteoarthritis, for example. That's a low-grade systemic issue, most likely stems from the gut. We're seeing gut microbiome and knee osteoarthritis now.
Wow.
People are drinking too much alcohol, they're eating too much saturated fats and processed sugars, trans fats. Obviously, saturated fats are okay in conjunction with good insulin sensitivity and fiber and all that stuff. But yeah, gut health is not good, and they're not exercising enough to buffer that low grade inflammation and to keep the gut well. So then we're creating a systemic issue. And then say they've got a flare up of their knee pain. Now, sometimes the flare up of the knee pain will be the knee swollen and hot. It's actually an immune event happening at the knee, which is sensitizing the pathway from the knee to the spinal cord. And then it's sending information up to the brain, and the brain's meshing together with everything in their world. It's happening, and it's going, okay, give this person knee pain. Now, when there is a tissue event, it's very influential to pain. It'll good. Yeah, it's a very strong influencer.
See, this is the head fuck, which is somebody presents with knee pain at a physio, let's say, and you and I have talked about this. And again, I'm going to sort of correlate my experience with my colleagues from a psych perspective and like trauma therapists, for example, and your experience with other, with physios, for example, or I'm not demonizing them. I've been to physios, osteos, chiros. I've had everything cracked. Before I had a hip replacement, I used to have that constant language of, oh, your hips are out. I'd have that same roll over, put your knee over, crack. I'd have psoas adjustments, every 3 weeks until I finally was told you need a hip replacement. I'm not saying I didn't need a hip replacement. I was told there was no cartilage there. I had symphyseal separation with both my pregnancies. So my hips, sort of almost dislocated with the weight of pregnancies. I'm very hypermobile in most of my joints. So, there's all these, as you said, it's complicated. It's not a matter of this is wrong and this is right, but it's the language that we now know just isn't reflective of reality, I think probably is the good language, because I know in my world, working with trauma therapists, working with other psychologists and psychotherapists, I'm finding very much over the last 3 to 5 years that even a lot of the modalities that I was taught at university that are being taught still at university don't have their feet planted in reality and have their feet planted in feelings, not facts, and theories, not facts. And we know that, for example, only last year it was absolutely categorically proven that depression is not a serotonin uptake issue, that it's not, that it's more likely an inflammatory response. And as you've just said, more likely a gut health and inflammation response than a chemical imbalance in the brain. But we've had decades of pharmaceuticals being put on clients and, colleagues with the best of intentions. I'm not suggesting people aren't doing it with the best of intentions, and it just isn't accurate. They would have been better off, which we now know, recent study, and I'll pin the study to this podcast, that actually exercise has just by a multitude of bloody, I think, almost 10, which is massive when you look at results, exercises outperformed SSRIs for help with depression and lifting mood, reducing inflammation, feelings of purpose and intention. So I come at that from a psych perspective going, unless there's action, most people need to talk less and pontificate less and move more and reduce inflammation. Look at diet, look at movement, look at sleep. 70% of your depression or mental health challenges are going to be over, but that's not very good for an industry that wants their books filled and to be talking to people and what I refer to as rolling around in the mud. So I'm a bit black and white with that. I'm like, a lot of this is bullshit. I'm calling bullshit on it. I know you're a lot more diplomatic than I am when you're communicating with people, but I mean, there is that difficulty with some of the other people in your industry, physios, osteos, chiros, etc., to shift the understanding of this pain science and that actually wrapping things, I had a client saying, I think it was a knee is out and I have to not move it, and I have to once the adjustment is settled, only then can I move. And I just sat there listening to the language going, that's actually
Yeah.
just delusional language. That's not accurate.
Yeah. Look, it's tricky because depending on if it is a tissue issue or if it's a pain system issue, the approach may be different. With certain injuries, we need to immobilize for a period of time. With pain system stuff, like it's about finding the dose and the sweet zone, and the person needs to really go through a learning journey, which takes challenging.
That's the point of what you just said, which is somebody might present with knee pain and it's a gut issue.
Yeah.
And I'm not, and so trying to educate somebody that, of course, I'm going to look at your knee and palpate it and see if it's inflamed and try and ascertain whether you've, and then they're either going to say, oh my God, I was playing touch rugby and I rolled and I hurt it, in which case maybe it's easier, but hard to get people to consider a gut issue when you've got knee pain.
Where I was heading before is with the, how I was saying about the knee might be swollen and then we've got a clear sign of an immune event at the knee.
Yeah.
Well, sometimes people who I've worked with will have, they'll have knee OA, but it's not why they're experiencing pain. It's more pain system. So sometimes they'll be experiencing pain because they've gone too hard, too fast into movement, which might flare and create an immune event at the knee, or they'll be drinking shit ton of beer, eating the wrong types of food and not sleeping well, and their stress is up, and then they're getting a local immune event. Other time it's not the immune system, it's their pain. They've had pain for so long that the stuff going on, they might be doing everything perfectly from a movement and loading perspective, but their pain system is just going, look, there's enough evidence that I need to protect the knee. So they're experiencing the same pain as if they were having a immune event happening in the knee. So that's what you call a mixed presentation. The cool thing is there's good resources now. There's the knee osteoarthritis handbook that's just come out by the NOI group. Natasha Stanton co-authored it with Professor Lorimer Mosley and Dr. David Butler.
Is she the one that was in Survivor?
No, that's Hayley Leake. Yeah, so she works at University of South Australia as well. But yeah, really good resource which goes into everything that I've been talking about, how it kind of interconnects and gets people moving slowly. But that is the battle, and that's probably why there's a lot of people out there who, a lot of clinicians that know this stuff, but it's just too hard.
Yeah, it's
or
so hard.
They'll try and drip feed some of these concepts, and if the person's not receptive, then they'll just go, look, it's too hard, and just
because you get accused, and I have, of being insensitive. I know you've been, because I know we've had it at Noosa Confidential. Are you saying it's all in my head? Are you seriously suggesting, you don't believe me? For me with psych, it's trauma and you're not understanding. I don't have the capacity, or it's real. And you seem insensitive when you're not buying into their distortion.
Well, that's the problem, is they're just trying to understand a concept. They're not understanding the concept, and they're getting defensive before understanding.
People get very attached, because let's talk about that, because this is the hurdle.
Well, the thing is,
people get attached to their pain and their story about their pain, and if you don't buy into it,
they're not ready to look at their misconceptions. So I think I was telling you about how for people to go through reconceptualization, they need to first want new information. They need to deem the source credible, and then thirdly, they need to start to see their own misconception of what they thought they knew, or what they think is fact or truth.
Yeah.
The thing is, people with pain system issues, their structure of their brain is different.
Yeah.
We see that with depression as well. Now, we know depression and pain is a two-way street. Sometimes it's the cause of the pain or part of a contributing factor. Other time it's a symptom of having long-term pain.
Yeah.
Now, they've got a central nervous system disease. That's what persistent pain is. It's not all in your head. It's all in your system, and it's getting mediated by everything in your world and everything you think you know about pain and everything you've been through in your life. So to say it's all in your head, factually, yes, it's all in your head, but it's all in your world.
Yeah.
And
your whole world is in your head.
Whole world, and your central nervous system is rooted now. But the positive thing is, if you start to change the way you see about it and start to do the work, it's going to be, it's going to change, but it's not going to be easy. I spent, like, I was just touching on my pain story, and it was just to try and give a timeline really quickly, but I spent probably 20 years in pain with my back.
Yeah.
And the reason why, and this is why I get a little bit pissed off about it, the reason why I was in pain for so long was because of the misinformation or well-meaning clinicians that I met throughout my journey that weren't giving me the right information. And they won't they were looking down holes for rabbits that weren't there. Yep. And we've got research that one's called the enduring effects of clinicians, I think, from lower back pain or something. It's a New Zealand paper, but basically the first point of call the person meets can change the person's trajectory whether they'll go into chronic pain or not.
But this is where we know that when somebody smarter than me was evaluating efficacy of psychological modalities, and categorically it's the relationship, the therapeutic alliance with the therapist that outperforms in terms of efficacy, or like you said, the trajectory that somebody goes down, more than any modality that is applied during any therapeutic alliance that's happening with a client, between a client and a therapist, meaning the impact that you can have off the back of building that rapport. Because as you said, people come to you and come to me because they want help. You would think that first criteria, that box is ticked. They want help. What is true, and well, you can say whether it's true for you. For me, people wanting help doesn't mean people are wanting to change the way they think. They want help. And sometimes I will have to say, I'm not the therapist for you because you really just want me to confirm a lot of your biases and listen to you, and I'm going to be challenging what you believe to be true. And wanting help and wanting things to be different isn't correlating to a willingness to challenge your beliefs and rewire your brain and consider a completely new concept of how you're experiencing pain in your life. And in my case, it's in your life, in your marriage, in your relationships. Is it hormonal? I just read a study last weekend about glucose and how women are more critical of their spouses when their glucose is low, and how over a 60-day period of a study with over 70 women, when their glucose dropped, they had dolls with pins. I can't think what those are called. And the amount of times that they stuck a pin in the doll, which was every time they got annoyed at their spouse or felt frustrated, correlated with a drop in glucose. So if I introduce that as a physiological explanation, because you're trying to meaning make and say, I'm really unhappy with my spouse, and every time he or she does this, and I say, maybe it's your glucose. Maybe it's not your spouse. Maybe it's not his attachment style or how he talks to you. Maybe it's your glucose. Maybe it's your hormones. Is it the same type of the month, every month that you want to leave? Is it, and you do a similar thing with pain. It's that, I can look at your knee, or we can evaluate your whole body. Of course, that's a responsible thing to do, but I'm also going to invite you to see things differently. And not everybody wants to do that. A lot of people want you to confirm their bias. I know you use virtual reality for some of that to try and educate people. And can you talk about the VR machine and how you use that to try and change people's minds and educate them about pain?
Yeah, we know the visual system is very influential. There's a little test that you can find on YouTube called the rubber hand illusion, where there's an experimenter and they're sitting face to face from the person they're testing on, and they put like a wall, a big bit of cardboard here, and they put a rubber hand on one side and they drape it so that you can't see your own arm, and basically the rubber hand comes out of the drape, and then your hand's behind the wall, and then they slowly kind of touch the rubber hand as well as your fingers, and all of a sudden they stop touching your finger and they keep touching the rubber hand, and your visual system takes over and you can still feel
it.
Person touching the rubber hand. Well, that's a pretty cool thing that's happening in the brain, where the visual system, we see that with other illusions, which which I can go
remember, sorry to remember where you're at about the VR. When my brother had a big car accident when he was about 13, and he was in hospital for 2 years, and there was a little boy in the same room as him who had his leg amputated from the knee down. and his mum made him a stuffed leg from the knee down.
Yeah.
And because he got phantom itches in the leg that wasn't there anymore, but if he scratched the pretend leg and really concentrated on it, he could get ease from the itching of the limb that was no longer there.
Yeah. So that's what we see with phantom limb pain is the person has no hand, but it's hurting. Now they don't have an arm, if not a hand, or it's gone. So there's no danger detectors, specialized cells that are sending information to the spinal cord.
Yeah.
Without that, it's either stuff in the spinal cord or the networks in the brain itself that is giving, meshing together, giving enough information that we need to protect our hand and giving us a perception of pain.
Yeah.
Now, for these people, we do a lot of mirror work with. I don't work at that end of pain. I'm more your generalized lower back pain, neck pain, different things like that. But they'll put the hand, the hand that they have in a mirror box, and they'll be able to see the hand that's not there, and they'll get relief from that. And then they can slowly start to titrate the volume and dose that they do that with that, and then it'll slowly wind down their pain system.
Yes.
Which is called graded motor. Yeah, it's called graded motor imagery.
Fascinating.
Cool stuff. I'd love to go and study, and get really in deep with it one day. But anyway, going back to the
VR,
reality system. So it's very influential when you're in VR, and it just allows for people to really understand or get them up to date with where we are with contemporary pain science without having to do a lot of the talking that we've just spent doing. And trying to educate them different types of pain, or pain's a broad thing of meshing information from our environment, our biology, and our psychology. So that's what the biopsychosocial model is, which means we're holistic. We can't separate everything in our surrounding and our biology from our reality or our perception of reality. But anyway, the VR system's a great tool in a toolbox that goes through and explains how the biology of pain and how many things can influence pain, many factors can influence pain. There's many ways that we can reduce pain, hence why people will go, I put magnesium on my lower back and it felt good, or I do this and it felt good, or I went and got a massage off this guy and he's the best guy in the world. Realistically, anything, if we take on a contemporary model of pain, can reduce your pain. It all depends on what your beliefs and attitudes and how you like to calm down. So for me, as soon as someone starts cutting my hair or just doing, that's something that I just drop into a deep state of peace where I'm super relaxed. People who have chronic pain need to try and find those things that help calm them down. Start to obviously move into exercise. When we do exercise and get our heart rate up to a certain point, we'll start to get brain food, so good neurotransmitter production, which will then drive changes to biology, but also it'll start to calm the pain system down. And then if we do weight training as well, the tissue quality starts to improve. What we're seeing in the research is over a 12-month period, as someone increases their pain knowledge, and the increasing pain knowledge, just for a point to add, will allow people to change behaviors.
Correct.
You learn about pain, you gain confidence. So you become confident in your recovery. You stop pain catastrophization, which is ruminating on your pain, magnifying.
Because you have evidence.
You've got evidence, and you're not getting down about it. So that's what catastrophization means. It's not the best word, but and then kinesiophobia or fear of movement. So their behaviors change. They stop avoiding and they start to move towards exercise. And the moving towards exercise or movement actually starts to change their biology. Their guts get better, their tissue quality gets better, their brains get better, their moods get better, everything starts to get better. And then that over time starts to lower their average pain throughout the week. Now, what we're seeing is we need at least 3 hours, around that 3 hours mark. The cool thing is
3 hours a week, you mean?
Yeah, to get your heart rate around that, 70% mark at least. Now, we see that as the national guidelines as well. It's about 2.5 hours, 3 hours a week to prevent what they call all-cause mortality. So we're seeing also the same thing with mental health. We need about 2.5. So it's like, aren't we just all talking the same thing? It's just we're having a different experience.
Yep.
So we really need to be moving at least 3 hours a week to not only get our mental health right, to get our gut health right, to reduce risks of all-cause mortality, but also to retrain our pain system. So it's pretty, I just find it so fascinating that it's like the answer is there. It's just, how do we do it? And that's why people go, well, I've tried exercise, it doesn't work. Now, that's about pacing. You need to slowly find where your edge is. The more sensitive someone is, the sweet zone's only very small. Now, some people just even need to think about exercising and they'll experience pain. And that's where we have, again, we've got different apps by the NOI group, which will be looking at different, for example, there's a thing called chronic regional pain syndrome, where the ankle tends to be limbs, distal limbs, so hands and feet, they get swollen and the skin discolorates. And it's to do with the immune system as well as the pain system becoming exaggerated. Now, they'll do a graded motor imagery where they'll look at like a foot, and it's like left and right differentiation. And that's kind of their dosage before they even start exercise. They'll be looking at feet. Is it a left, is it a right foot, or is it a left hand? And that's their way of starting to kind of calm the system down to even start to move or do a specific ankle work.
I've got a client in Melbourne, and she used to be very active. I think she's about the same age as me, maybe a year or two younger, so in her early 50s. And she had, so in inverted commas, chronic fatigue, and she's just started challenging herself with literally like, I think 7 minutes 3 times a week of Pilates. And she said, I know that the movement is just the brain training, that because otherwise she gets malay after exercise.
Yeah.
That's her language. And she just contacted me this week saying she's just got to 20 minutes twice a week and is heading up to sort of 30 minutes twice a week.
She's pacing beautifully.
Yeah. She's like, it'll take the next 6 months, but I want to get back. I realize I've really bought into this. I can't exercise. I get sick after I can't do anything. It's like, if I can do 5 minutes or 7 minutes for a month, and then 15 minutes, and then 20 minutes, and then she'll eventually, her aim is to do a hike in Tasmania. But yeah, it's the understanding dose in your language, pace. The same with my language with my clients. Like, I do walk and talk because movement and talking, the movement's probably going to do more than the talking. Let's face it. It's going to reduce inflammation. I'm going to listen to you. Hopefully I'm going to give you some good feedback. But ultimately, walking is probably going to do more for you than the talking.
Yeah.
That's the truth.
Yep.
It's been a big one for me as a psych and as a therapist, and even with couples, go for a walk together, move your body together, reduction of inflammation, open, better communication when you're not facing each other and you're side by side. And the minute you start getting evidence that you can do something, then you're more likely to feel confident. When I'm trying to increase or improve intimacy with a couple, I will ask about their individual movement, because how they feel, particularly women, about their bodies, but men as well, does correlate to intimacy in the relationship. So there's just so many areas that how we feel in our body, our perception of the problem and the solution that is actually helpful. You and I often are talking the same language.
Yeah, which is great. It's we've got friends.
You and I.
Yeah. That's why I joined Pain Revolution, because it can be very isolating if you're, it's not common knowledge at the moment, and there's people taking on the message and understanding it deeply, and there's people that are avoiding it at all costs because it goes against their biases.
Yeah.
And look, we're not going to have everything completely 100% accurate. We're constantly learning. Yeah, and that's what science is testing, retesting,
constantly evaluating. Exactly.
Truth. So I'm not saying I know everything, but I know far from the truth. But the thing is, it seems like we're on the right direction in taking a broader, a holistic approach to pain. And the further down the rabbit hole we go, we're seeing that we are generally linked in to our environments, our biology, our psychology, and our behaviors within that realm.
Very true.
Yeah, I had something to say, but I was kind of, I think it was about avoidance. So you mentioned something about avoidance earlier. I think where we tie in those old ways of thinking with tissue issues or malalignment and all that stuff is when we have had pain for a long time, depending on if the person is an avoider or an endurer, sometimes that painful area will be either weaker or stronger if we do strength testing. I'll go through and do kind of isolated joint range of motion testing, and I'll find it'll allow for me to see if the person is provoking their pain by being impatient and going too hard too fast, because generally that'll be like a stronger side, or if they're avoiding loading that area completely, it'll be a weaker side. But yeah, we can have some stuff at the tissue like osteoarthritis and tendinopathies, which are like a mixed presentation as well. But yeah, it's complicated, but it doesn't have to be super complicated. It's just people need to be open to new information and realize that it's a journey. It took me 3 years to have really big gaps in pain, because as people start to recover, the distance between their pain episode gets bigger, and the severity of the episode decreases. But people go, you go, how's your back? Oh yeah, I had pain. Okay. When it was all the time? Oh no, on Tuesday. What was it? Oh, 2 out of 10. Well, do you realize 2 months ago you had constant pain all the time? Oh, yeah, I didn't realize that, because they're still in it. You know what I mean? People need to see the small wins, and then it's a 1% change, and it's a long-term thing.
Correct.
Yeah? But anyway, like for me, generally I don't have any pain because I've had changes to my pain system. I'm more likely to have pain without the presence of tissue issues when I'm not sleeping that well, when my stress response is up.
And mine's the same, right? I mean, you and I work together 3 times a week, and
dynamic. Doesn't mean it's just we've had changes now, and unfortunately, we'll be more protective in our system. But I don't see it as a problem, because it's going to keep me aligned.
Yeah, me
with
too.
Health promoting behaviors.
Once you know that, you stop catastrophizing. You're like,
totally.
Tyson and I train together, and I'll say, and he'll say, you're not sleeping. Or for me, when I'm in the stress state, I mostly cope, and once the stress time has passed, my pain pathways will start to be inflamed, and I'll go, oh, my ankle hurts and my back hurts, and I feel like my language will be, I feel like my back's about to go. I've got this whole story running. I feel weak. I feel incapable. And that always correlates to my mental state. Always. Yeah. And then you'll say, let's lift, or you'll even have me lifting heavier. And in a minute, I prove to myself I'm not weaker. And actually, I think I usually do a PB when I'm in that, can't do it. And then you get evidence that that's not true, and you can't not shift once you get that enough.
The thing is, like, the bigger the longer down the pathway, if you're hitting that 3 hours. I love weight training, because what it does is it builds the tissue quality, challenges your own beliefs around what your body's capable of doing. But the longer you go down pathway in building strength, in my experience, your capacity to handle life events and increases in in stressors in all our life gets better.
Well, let's leave it there. That's been a really good start to, a conversation about pain, about neuroscience, really how our pain influences our behavior and how we feel, and challenging the stories that we have about pain. So love to have you back on down the track and talk about it more. But for now, thank you so much, Tyson.